Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will learn about the anatomy and the applied aspects of the sixth cranial nerve, that is abducens nerve. So in this video we will discuss about the abducens nerve, that is the exact anatomy of the abducens nerve, which are all the various other structures which are in close relation to the abducens nerve. What are all the causes for sixth cranial nerve palsy depending upon the anatomical locations. So without much delay, let's begin our video on abducens nerve anatomy and the applied aspects. So it's a pure motor nerve and it supplies the ipsilateral lateral rectus muscle leading to abduction of the eyeball. So we have various parts of the abducens nerve. First is the nuclear part, fascicular part, subarachnoid part, petrous part, intracavernous part and the intraorbital part. So we have 6 parts of the abducens nerve. This is how the course of the abducens nerve is. So first we have the nuclear part from where the abducens nerve will origin, and then we have the fascicular part, then the subarachnoid part, and then petrous part, cavernous part and intraorbital part. So this is the overall view of the abducens nerve. So coming to various parts now, the first is the nuclear part. So the sixth nerve nucleus is situated in the floor of fourth ventricle beneath the facial colliculus in the lower part of the pons close to the midline. If you see in this picture, this is the fourth ventricle what we have. So it is situated in the floor of the fourth ventricle. Okay. So this is the one more picture which is showing the exact location of the sixth nerve nucleus. So we have the sixth nerve nucleus here, which is situated in the floor of the fourth ventricle. So the sixth nerve is situated in the lower part of the pons. As you can see in this picture again, the facial nerve nucleus is here and the facial nerve fibers are looping around the sixth nerve nucleus, producing what is known as facial colliculus. I think you can appreciate in this picture, these two are the facial folliculi which is produced by the loop of the facial nerve. So our sixth nerve is just beneath that. So this is again one more picture which can clear your doubts. So here we have the abducens nerve nucleus and we have the facial nerve nucleus. The fibers are looping around the abducens nerve nucleus, producing what is known as facial colliculus or the elevation in the pons. Okay. And if you take the cut section at this point, we have the abducens nerve nucleus and the other structures which are in relation to the abducens nerve nucleus. So we have the abducens nerve nucleus, that is sixth cranial nerve nucleus here. So we have some structures which are medial to it, which are very much important. They are nothing but the medial longitudinal fasciculus as well as the PPRF, that is nothing but pontine paramedian reticular formation. And lateral to it we have the cranial nerve fifth, that is the trigeminal nerve nucleus. That is the main sensory nucleus of the trigeminal nerve is situated lateral to the abducens nerve nucleus. And ventral to the nucleus we have the pyramidal tract. Okay. And one more important thing about the sixth nerve nucleus is it will give some fibers to the contralateral medial rectus subnuclei of the oculomotor nerve, which is responsible for the horizontal gaze. So if there is a nuclear lesion, it will affect both the abducens nerve as well as the horizontal gaze is affected. And this is nothing but the MLF or the medial longitudinal fasciculus. Okay. This is one more picture which is showing the same connection now. This is the sixth cranial nerve nucleus and it is sending some fibers to the contralateral oculomotor nerve nuclei which is supplying the medial rectus muscle. So it will lead to the horizontal gaze palsy also whenever there is abducens nerve palsy. So which are all the causes for sixth cranial nerve palsy at the nuclear level? Pontine infarction, pontine glioma, cerebellum tumors and the Wernicke-Korsakoff syndrome, that is nothing but alcoholic encephalopathy. So these are the various causes for nuclear lesion. Next, moving on to the fascicular part. The fascicular part is nothing but the course of the sixth nerve in the brainstem. So as you can see in this picture, this is the abducens nerve which leaves the ventromedial aspect of the nucleus and passes ventrally to exit the brainstem at pontomedullary junction. And it passes just lateral to the pyramidal prominence. So the lesions here depend upon which part of the pons is affected. So if there is the affection of the dorsal pons, then there is affection of the facial nerve also, which will lead to what is known as Fovill's syndrome. That is nothing but the facial nerve palsy as well as the abducens nerve palsy. So if the affection is on the ventral side of the pons, that is the ventral pons is affected, then there is affection of the pyramidal tract also, leading to what is known as Millard-Gupler syndrome. Okay. So the fascicular part can be affected by the vascular diseases like diabetes and hypertension, demyelinating diseases and even the tumors. Next, coming to subarachnoid part, that is the course of the nerve after it leaves the brainstem. So once it leaves the brainstem, it enters into the subarachnoid space. Then it courses upwards along the clivus, passing between the pons and the anterior cerebellar artery before penetrating the dura mater. So this is the subarachnoid course. The nerve can be affected here by the nasopharyngeal carcinomas, chordomas, meningiomas, and even the raised intracranial pressure. So as you saw, the nerve was originating from the nucleus, and then we had the fasciculus part, then we had the subarachnoid part where the nerve was climbing upwards along the clivus. Then it will come to the petrous part. Once it comes to the petrous part, it passes around the inferior petrosal sinus beneath the petroclinoid ligament. Here you can make out this is the petroclinoid ligament, or also called as Gruber's ligament. Then it will enter into the canal which is known as the Dorellos canal, which is situated below the dura mater and just above the temporal bone. So this part of the nerve is very much vulnerable to the trauma with the involvement of the fractures of the temporal bone or infection from the mastoid produces what is known as the Gradinegos syndrome. After this, it will enter into the cavernous sinus. In the cavernous sinus, the sixth nerve runs horizontally forward in the middle of the sinus. The Abducens nerve is in the middle of the cavernous sinus. And in this course of the nerve, it is joined by the sympathetic branches of the paracarotid plexus also. If there is any affection of this nerve in this intracavernous part, then there can be involvement of the sympathetic plexus also, leading to post-ganglionic Horner syndrome along with the sixth nerve palsy. So this is intracavernous part. Then it will pass through the superior orbital fissure and enters the orbit and supplies the lateral rectus muscle. This is in brief about the anatomical course of the sixth nerve along with its applied aspects. So hope this video is helpful to all of you. If you like my videos, please do subscribe to my channel. Press the bell icon for further notifications. Please do like and share my videos. Thank you so much.